You're all behaving so well today. Thank you. I think this is the one I requested about sleep. Okay. And what you really pay attention to, this is important stuff. Dr. Bohra, a second-year rheumatologist fellow here at MetroHealth Medical Center, is board certified in internal medicine from Reading Hospital in PA. Doctor attended medical school, and I'm going to butcher that one, Kathmandu University School of Medicine in her home country of Nepal. She has a career interest in general clinical rheumatology and the use of musculoskeletal ultrasound and is dedicated to compassion about patients and families with autoimmune diseases. She's going to present to us today about sleep. Thank you for coming.
Good morning, everyone. Thank you for joining us this Saturday so early and giving your time. My name is Nidrit Bohra, as I've been introduced. I'm a second-year fellow here at MetroHealth Hospital. And day by day, every day, we see at least like a couple of lupus patients. So it's like makes a huge cohort of the patients we see in the clinic. And I think Miss Tierney requested this topic, but I also chose it because it's also pretty personal to me. As somebody who struggled with like sleep disorders for like most of their adult lives, it's a personal topic. And I find like looking at like statistics and data and research ongoing on the topic pretty helpful. And this is also one of the questions I get asked by my patients a lot. So I thought it would be interesting to talk a little bit about this. I'm going to try to advance my slide. Okay, so sleep is an active process in which metabolism, tissue restoration, and general homeostatic balance is maintained. What do we mean by that? So all the time while in our wakefulness state, our organs are working full time. And when we are sleeping, that's the only time when actually restorative functions are happening. It's basically like your body's getting in this relaxed state where actually anabolic or developmental processes happen. Anything that's damaged gets healed. So it's something that's vital to the body to maintain, make sure the body is able to take another day again, go day by day, do its full activity. So it's something very vital to your body to make sure it's functioning well. Sleep disturbances have emerged as a major determinant of psychiatric and somatic health. And in our patients with lupus and other autoimmune diseases, sleep disturbances have been found to be something that's like a major determinant of how their disease activity does in general, how it influences their mood directly. So this is all like a vicious circle. So just looking at the prevalence of lupus or SLE, there was a study done in 2008, and I think that was a study done in Stanford that showed that the prevalence of SLE in US is about 1.5 million Americans, and that's in 2008. So the statistics might be even higher or different at that time. So now in 2022, there was a study done that showed that the incidence rate of SLE in the general population is about 20 to 70 every 100,000. And those are high numbers. So having that information, what is the statistics of sleep disorders in these patients? So about like 56 to 60% of SLE patients that was looked at in that study in Stanford showed that about 56 to 60% patients had sleep disturbances. They reported fatigue. And this study was specifically done to look at like the association of sleep disturbances in these patients. Up to even 80% of SLE patients have poor sleep quality. And the prevalence of sleep disorders range anywhere from 50 to 81. That's more than half the patients. So, I mean, why do we need sleep? I touched on this a little bit, but basically it's the primary thing your body needs to restore energy, eliminate fatigue, restore strength, enhance immunity, and to promote development of tissues, whether it be other like tissues in the body, or like whether it's like neurons or like your brain cells. And the topic of immunity is also interesting because in the past it was thought that patients with lupus, because of the disease activity, they had impacted sleep, that they weren't sleeping well because their disease was very, very active. They were in a lot of pain, they were having mood disorders. But there has been more and more study coming out these days that sleep has a direct effect on immunity. So sleep is something, if you're losing sleep, your body goes into a state where it's almost inflammatory. It's an insult to your body. So there's a lot of chemicals released in the body, which are irritant chemicals, which we like to call cytokines. There are good cytokines and bad cytokines. So there's a lot of inflammatory cytokines that's being released in the body, and that almost predisposes you to these autoimmune conditions as well, makes it vulnerable. So, and that's what I mean by sleep and inflammation have a bidirectional relationship. So if you have SLE or you have autoimmune diseases where there's a lot of disease activity, you have like abnormalities in the organs in your body, you're in a lot of pain, that itself can affect how you're sleeping. If you're hurting all the time, obviously you're not going to sleep well at night. So that's established. But the other thing I'm trying to also point out is there were studies done, large-scale studies done, where they looked at whether people with sleep disorders um, were found to have like a higher or like rate of SLE than people who didn't have those pre-existing sleep disorders. So basically, the lack of sleep is an insult to your body that can alter your immune system and how your immune system functions. And we all know lupus is a disease from imbalance or breakage in that immune system barrier. You have abnormal immune systems. So, sorry. That's why I say lack of sleep is a pro-inflammatory state. Pro-inflammatory meaning it's supporting inflammation. And there's like a continuous cumulative cytokine imbalance. So it's like day by day, sleep is everything. The more you sleep, you're losing the negative cytokines, or the inflammatory cytokines are accumulating in your body. And that directly also promotes immune dysregulation and autoimmunity. When there's immune system dysregulation, again, your disease activity is higher, meaning your clinical symptoms that we evaluate are higher. There's more like pain, there's so much overwhelming fatigue. It also negatively correlates with your mood symptoms. There's found to be a very high population or statistical correlation of mood disorders with our patients in lupus. And that, like, again, it's like that has a bidirectional relationship as well. If you have a mood disorder, if you have high anxiety, high depression, your sleep quality is directly affected. And then that alone, again, promotes more disease activity. You just don't feel well generally. And with lupus, the more medication options we have to treat them, the medications, yes, help control disease activity, the things we are trying to target and control, but they can also worsen your insomnia or your sleep disorders. Like just generally talking about steroids, we use a lot of high dose steroids in our patients when they're in the hospital with something acute. Let's say their kidney function is abnormal, their cell numbers are dropping. We need to say, okay, we need to give you high doses of steroids. And my patients, when I go to check on them the next day, they're saying, I couldn't sleep all night, I was so fidgety. It's somebody who's never taken steroids now getting like up to 500 milligrams of like steroids per night. So it definitely impacts sleep. And steroids and our lupus patients are like, I think, the longest lasting relationship we have so far. But we also need to be aware that these medications can also directly impact sleep and our quality of life. There are other like medications as well that we use as steroid sparing agents. So they may also play a tiny role here and there in affecting your sleep quality. So oftentimes when we talk about sleep issues, these are the things that we need to look at the fine print. What medications are you on? Could they be playing a role? Is it just your disease activity, or is it other things that could be impacting this? So sleep may influence systemic lupus erythematosus activity through an endogenous hormone called melatonin. We all know about melatonin, that it's produced in the pineal gland. It like maintains your circadian rhythm. There was a recent study, large study that was done that looked at patients with lupus and their melatonin levels, and found that lots of lupus patients had low levels of melatonin in their blood and also low levels of vitamin D. So, and there have been studies that have linked that this lack of melatonin may also have a direct function on like making your immune system abnormal and then predisposing them to lupus. So these are things that are currently being studied. So far, the melatonin, just a hormone supplement that we take over the counter, research has shown that they have not been very beneficial in treating these sleep disorders or improving like sleep latency, or meaning like there are some people who have issues falling asleep. There are people who have issues just staying asleep. So these medications have not shown a very significant role in improving them. But then identifying that the hormone is actually related to these sleep disturbances may open doors in the future on what agents it can work for this, what doses of these medications may be beneficial, how, in what routes should they be taken. So it's an interesting finding that I thought I wanted to highlight, because there's so much talk on melatonin. But the over-the-counter supplements we use right now aren't like very beneficial, which is why I didn't include that. So the melatonin hormone, the way it impacts your immunities, basically it's an anti-inflammatory hormone as well, on top of also regulating the circadian rhythm. And like I said, there was lots of case control studies done. So case control studies are studies that are done using patients with like rarer disease. There's a lot of investment that goes into it, but basically they're looking at disease states and analyzing what other factors could be associated with these conditions. So this is the vicious circle that I was talking about. This is the interaction of poor sleep and lupus activity. So the lupus activity is in the center there. So there's sleep distress, immune dysregulation, lots of inflammation, cytokine dysregulation. Again, these are like chemicals in the body, proteins that are released when there's a pro-inflammatory state. And there's melatonin and circadian rhythm disruption. So all in all, it creates a vicious circle where your disease indices are high, your activity is high, and you're also not feeling great, you're tired, and then you're like struggling with like sleep issues. So let's touch on management a little bit. So there are specific and non-specific treatments for sleep. Anybody who's talked to a physician, when they say, I cannot sleep, I'm pretty sure everybody has heard about the sleep hygiene. I have. It's easier said than done, but I also say that this is like a mantra that you have to stick to all the time. Nobody is responsible for like fixing your sleep but you. So you always have to be active, keep like thinking about these things, and make a conscious and active effort that you're doing something, at least one step every day, to improve your sleep hygiene. Especially challenging in this day and age because we're all hooked to our phones. We have so many other stressors and distractors. So finding that quiet time in yourself to actually engage in activities that can improve your sleep hygiene is very, very essential. So it needs commitment. So there's this dysregulation of the sleep and rhythms of the body that causes sleep disorders. So the management requires that we regularize both behavioral and physiologic functions. Psychological methods for improving circadian sleep-wake behavior are also important and beneficial. So that brings in the role of therapy, cognitive behavioral therapy, and things like that, addressing mood disorders, So sleep hygiene enables the regulation of circadian rhythm of sleep wakefulness, where the pattern is otherwise disorganized because of faulty sleep habits. If we go to bed, let's say, we find that we're well rested, like we go to bed at 2 o'clock at night and then we sleep until like 12 in the morning, you are getting 7 to 8 hours of sleep, but you're fighting everything that nature has trained your body to do. That's not, your body releases these hormones in your from the pineal gland to say, oh, the sun is out, it's time to wake up, you have to stay active. So I think people who are not like trying to regularize those rhythms struggle more, and it's not by choice. People work third shifts or things like that, but if you are struggling to a point where you're like your quality of life is poor and you want to make a change, just making that change is easier. um, Two of the most common faulty habits, like I said, are variable bedtimes. Again, trying to aim for required number of sleep hours, but not making sure that you're going to bed at the same time every day. Even like waking up at the same time, it's very crucial. And other is inadequate nocturnal sleep time. And that's where I pointed out the circadian rhythm. So you are sleeping, but it's probably more in the daytime. It's not happening at night where your circadian rhythm supports that your body is the most relaxed and getting the most out of it. So those are two common mistakes that we see, or faulty habits that we see that drive sleep disorders. Reducing psychologic distress, anxiety, and depression. Still, in this day and age, still there's a lot of taboo associated with it. People don't want to address it. This is something where we have to actively work on it, recognize the issues that you're dealing with, seek help, whether it be through therapy, whether it be through talking to family and friends, whether it's be to talking to your providers, getting started on the right set of medications. Reducing psychological distress is very, very important. Reducing environmental noise. Personally, for me, that makes a huge difference. I'm a humongous believer in using earplugs. So people who have, cannot avoid environmental triggers, noises, or things like that, then using earplugs is a good. Lots of people swear by white noise generators. I find like the rain sounds very calming. Some people like other noises, so things like that can help actually. I have patients who tell me that they use a slow fan and they like the sound of it. It's soothing. So whatever works. Avoid having noisy or restless animals sleeping in the bedroom. We all love our pets, but if they are impacting the way we are sleeping because they want to cuddle too tightly with you, then that's something we need to change. I was dog sitting for one of my friends once, and she was like a 50-pound dog, very shy, and she was somebody who was so timid, just wanted to cuddle next to me all the time. At night, every time I would try to turn, she would throw her huge body against my back and wake me up. And I slept so badly. I loved the little baby, but I had to put her out of the room. So things like that. And this is my joke of the day. A spouse who's loud snoring or restless sleep, they should be put out of the room too, like I do with my husband, but that's something. And like, yeah, explore why they're snoring so much. Maybe they have sleep apnea and other issues or disorders that need to be stressed. Sleep is something both of you need, and it helps improve your relationship as well. So those things need to be addressed. Reduce caffeine and alcohol. Caffeine is such a big part of our lives, but let's try to stick to timelines where we cut off caffeine after a certain time of the day. Make your own clock. Tell yourself, I'm not going to take a cup of coffee after 12 or 1, even if it's like, try to have other distractions where you're not reaching for that extra cup of coffee late in the day. Water is something that's very, very necessary, but make sure you're not chugging humongous, cups of ounces of water after 4 or 5, because you'll be waking up all night peeing. And alcohol, again, alcohol is something it's had a conflicting relationship. People say it helps them calm down, sleep, makes them sleep better. It can actually make you fall asleep faster, but then it'll also like disrupt your later half of the sleep, which is your deep sleep or your like and non-REM and REM sleep, the way that you wake up much faster. There's no maintenance of sleep when you're drinking large amounts of alcohol, so you don't get that restful sleep. You feel like you're sleeping, but it's not restful. Behavioral methods that reduce psychological distress, such as hypnosis and biofeedback treatments, are also reported to be helpful. Now, these studies were done more with lupus patients who had fibromyalgia. There are no active studies which have directly looked at what modalities have been helpful with patients with lupus and sleep disorders, but again, about 70 to 80% of our patients with lupus also have overlapping fibromyalgia. So even these modalities can be directly correlated and implemented in our lupus patients who do not have fibromyalgia. Hypnotherapy may be helpful in improvement in muscle pain, fatigue, sleep disturbances. Physical methods, massage, which is my personal favorite, acupunctures, those are things that can provide temporary improvement. And very important, appropriate neck support to be used at night. Reduce any kind of cervical strain, muscle strain on the neck when you're sleeping at night. Fibromyalgia itself causes you have so many tender points in your body, you're just so sore that if you're not using adequate support in the neck at night, then that's going to significantly impact how you're sleeping. You're going to be waking up, tossing and turning all night. And also it reduces your risk of like nerve entrapments and things like that, more cervical injury, radiating pain along the arms. So if you can make small corrections like that, that's very beneficial. Effort should be directed to stabilize the regulatory functions of sleep by going to bed and awakening at suitable and specific times. Suitable times meaning preferably in sane night hours where the rest of the people try to sleep, and awakening at fixed times, like train your body, set up a fixed waking time for yourself. The first initial days you may be tired, but then your body gets used to it, and then you'll start falling asleep better. Go to bed when you're actually feeling asleep. Don't use the bed, only for like sleeping purposes. Don't stay on your phone on the bed. Don't use it like a place where you're like, you watch TV or do things like that. While sleep needs vary from person to person, and I say that again with a comical hint to it, because I Googled something. There's a population of patients who are called the sleepless elite. They function with less than 6 hours of sleep, and I like to think that I'm one of them. But for normal for other people, usually they require 7.5 to 8.5 hours of sleep to be functional, to be regenerating, to be recovering well. So target for those amounts. Establishment of regular daily routines not only includes meeting sleep requirements, but healthy diet and exercise. So there's so much, in the market these days or online about different types of diets, anti-inflammatory diets. All of them have their own unique purposes and benefits. I do not claim that any diet is better than the other, but I think we can all make a conscious choice in selecting better whole foods, whole grains, stay away from less junk, trans fats, things like that. Those are small changes we can make. And you eat better, you feel better. And again, when we talk about exercise programs, that's also one of other things easier said than done. But what I would say is gentle graded aerobic exercises, and select the time that you're doing these exercises too. Research has showed that patients with lupus, fibromyalgia, just because there's so much burden of physical pain that you're suffering with, exercises done between the times of 10 to 3 p.m. is most beneficial. It allows for muscle recovery. It doesn't make your mind hyperactive. If you're exercising at 9 p.m. at night and try to sleep at 10 p.m., it's probably not going to work out. So keeping that healthy gap of time where you're more active is also good. And again, exercise necessarily doesn't have to be vigorous. Like Dr. Petralia pointed out earlier, any amount of aerobic fitness that you can fit into your busy day is important. Research has shown that aerobic exercise, water exercises, tai chi, things like that are things that you can make small implementations in your daily routine that would be helpful. So overall, we talked about more non-specific treatments. Now we're going to touch a little bit on specific sleep treatments. Overall sleep hygiene and non-specific methods provide a very suitable background regimen that you can use like your mantra on regularizing and facilitating sleep. Medications in lupus patients and fibromyalgia patients, they're tricky. There is no one solid medicine that has said, oh, it improves all qualities or disorders of sleep that's affecting these patients. But there are some medicines that help with certain aspects. So those pharmacologic treatments that have been well studied in the market, drugs which have been in the market 30, 40 years, we kind of feel like we've known them. There's a lot of safety data that's there. So it's easier for us to recommend things than something that popped out last night and is taking the world by the storm. So things like tricyclic antidepressants, which also regularizes or balances the serotonin hormone. Serotonin hormone imbalances are something that's directly linked with anxiety and depression. So these medications that influence or correct the imbalances of the hormones actually have been found to be beneficial in addressing sleep disorders and also in reducing pain in lupus and fibromyalgia patients. Drugs like cyclobenzaprine and amitriptyline, like I said. But the catch is their effect is short lasting, up to 2 to 3 months in some research, and in other like larger double-blind studies, they lost their pain reducing effect after a month. So there's help with sleep, but there's no direct reduction of pain on using these agents. Sleep EEG is something that I feel like we probably underutilize. And I say that because sleep disorders, I mean, again, trying to go into the slight type of sleep disorders is beyond the scope of this talk. But there are lots of disorders, primary sleep disorders, insomnia, or other associated secondary disorders like sleep apnea. You have restless leg syndromes, or you have circadian rhythm disorder and things like that. So tests like sleep studies and EEGs can actually help determine what kind of disorder you're actually dealing with. Is there something that's correctable by medications, by taking supplements, or correcting some lab errors, or like lab deficiencies like iron deficiencies or things like that? That's something that can be picked up. And when you have information, you have more options to treat. There were studies done in patients with lupus and fibromyalgia, which showed that most patients with fibromyalgia have something called an alpha sleep disorder. So alpha waves are something that suggests light wakefulness. Your body goes through several cycles of sleep when you're sleeping, initially starting with like light sleep, then you go into like the non-REM sleep, which occupies 45% of your sleep cycle. There are various stages of non-REM sleep, and you go deeper and deeper into sleep. And the last stage is REM sleep, which is 25% of your nightly sleep cycle. And research has showed that patients with fibromyalgia and lupus, they tend to spend most of their nights in the alpha wave sleep time, where they're light sleep, but do not go into the deep restful sleep. So they're sleeping, but they're not really recovering, waking up tired, and this directly impacts how fatigued they feel the next day. But unfortunately, so far, none of the medications that I'm talking about, or I will be talking about, have shown direct benefits in correcting those alpha sleep pattern abnormalities. So that's something that we are hopeful in the future. Lupus is something that has caused us like to brainstorm for 50+ years, and we're still brainstorming. But I always stay hopeful that things will come up in the future that will be helpful. Traditional sedatives and hypnotic benzos do not provide much specific benefit. And we also try to stay away from them because of their humongous dependency potential. Non-benzodiazepine hypnotics like zopiclone, zolpidem improve subjective sleep, meaning what the patients are feeling, and daytime tiredness. But again, like I said, they do not modify the alpha EEG sleep, nor are they actually benefiting the pain syndromes. Very common agent, diphenhydramine. It's a histamine receptor antagonist. Very common thing in sleep aids. Can help with mild insomnias, but again, morning sedation, tolerance. So after some time of using, you stop responding to it. There's a lot of data on valerian root extracts. I think you make sleepy time teas with these things. They're common. The problem is there's a lack of a standardized available product. And again, we are missing large scale studies, which is actually shown benefit in the population of target for us. Tryptophans, the L-tryptophan is a mild sedative agent. It's a precursor of the hormone serotonin, which we are talking about. Smaller doses, not very effective. Larger doses in 100 milligrams have in recent studies shown to improve pain and sleep quality. Again, we do not have much information. This is new. We need larger studies and more trials to see, is it actually beneficial? What aspects is it helping on? So these are some things to look forward to in the future. So while I'm ending, I would like to emphasize sleep disorders, diagnosis, and management of primary sleep disorders is very important. Sleep studies can help in diagnosing whether it's a primary sleep disorder, what kind of other associated disorders am I dealing with? Is there something like sleep apnea that we can address? If there's sleep apnea involved, we correct it with CPAP use. If there's a restless leg issue, there are medication that can treat it. If there is restless legs due to iron deficiencies or things like that, we can treat it with iron and other treatments. So there are correctable things. But again, we have to bring ourselves to the point where we're actually looking for the diagnosis. And treating restless legs, some people, especially women, suffer from horrible restless legs during pregnancy, and their lives are miserable, and just correcting those things that they're lacking in, like most commonly iron or ferritin, has made like considerable differences in their quality of life and sleep. So these are things we often miss. And I think that's my last slide with some references. I've talked too much and taken more time. I apologize, but I hope all of you can at least take one take home point from today. And thank you for your attendance and your time. And thank you. Oh, I forgot the questions. I was trying to run away too fast. Sorry. Hi. Hi.
I have a question. You're in a lot of pain if you don't receive pain medication.
Mm-hmm.
You said wine is okay to help go to sleep. How many glasses of wine?
Yeah.
But Monday through Sunday, like if you're having 4 days where you really can't sleep, is it okay to drink a glass of wine with all of the medication that you're taking?
Mm-hmm.
Is it going to affect it at all in any type of way?
Okay. So the question was, she's asking because she struggles with pain and not being able to sleep because of the pain. And as I brought up alcohol in there, is it acceptable to drink small amounts of alcohol that can help you sleep better? So if it wasn't clear from my slide earlier, I apologize. But the reason I brought up alcohol was it can give patients this faulty sense of being feeling sleepy, and they're actually sleeping better. So what it does is it reduces the sleeping time. You fall asleep faster, but then all of the other stages of sleep that you actually need, where you're falling into deeper sleep, which you need for restorative functions, for relaxing, recuperating, those stages are skipped or meddled with, so you're not actually sleeping better. You wake up faster. You wake up in like 2 to 3 hours of drinking, and then you cannot fall back asleep. It certainly impacts the kind of sleep you have. So personally, I would not recommend trying alcohol or wine to help you sleep better. So that's not something I would recommend. I hope that helps.
Which beer say you can't have a glass of wine. It's not just always.
I mean, if you want to try a glass or two when you're socializing with friends, at other times, yeah, but I would say try to avoid it closer to bedtime. I'm not going to tell everybody to say completely abstain for every single thing that gives you a little bit of joy when you're socializing with people, but we have to be mindful to, like, again, that comes into a part of sleep hygiene. So try not to take those things closer to when you're sleeping.
So, if you have a very bad immune system,
Mm-hmm.
that was the second part of the question.
Mm-hmm.
How do it affect you? How do you know, like, this is not, I got that.
Sorry?
I'll ask later.
Oh, we'll talk later? Okay. Save all your questions for when you see me. Thank you for being kind. Okay. Oh, no. Mm-hmm. Yeah. Mm-hmm. Because it's a safer alternative, and it, I think, helps with sleep latency a little bit. It helps you sleep faster. But then there are, again, like I said, with sleep disorders, there are various issues with different kinds of um, disturbances and how much time we spend in different cycles of sleep. It has not shown to improve those. Like, let's say you're tired because you're having too little non-REM sleep and more of the light sleep, it actually doesn't correct those. So it's a safer alternative, something that you do not have dependency on. But again, it improves subjective sleep. Subjective is a word that patients perceive. It, and again, like, there are lots of agents like that in the market, which improve subjective sleep quality. It's a safer alternative. And like I said, there are agents similar to melatonin that are being investigated. Maybe they will be shown to have effects in the future that can be beneficial. Right now, we don't have solid data on melatonin actually improving sleep quality, which is why we don't say use it as a therapeutic option.
So if a lot of sleep problems are caused by anxiety,
Mm-hmm.
is it smart to take anxiety medication to fall asleep?
So that is if your anxiety is active and you're also suffering from sleep issues, that's a discussion that you have with your psychiatrist or whoever is treating the anxiety, because it's easier if you can treat two conditions with one medication. So if you can take an anti-anxiety pill like the tricyclics or the amitriptyline, which helps, has a mild sedative effect and helps you sleep and also controls your anxiety, then that's something they can work on. But just because an anti-anxiety pill has a sedative effect, it should not be used just to treat sleep if there is no anxiety component to it. Again, medications, you're committing a long part of your life to these medications. So anything that you can avoid not getting into, you can. Things that need medications, yes, you should commit to it full and wholeheartedly. But I do not recommend just using those agents for sleep. But if there's significant anxiety, yes, that's a good option. Mm-hmm.
know when they lay down.
Yeah.
When they lay down, all of a sudden the reality is you stop and the pain is everywhere.
Yeah. Yeah.
Sleep, mood, restless, waking, get the whole gambit coming.
Mm-hmm.
But I also suffer, full disclosure, I also suffer from depression.
Mm-hmm.
Okay, so I'm taking a pill to get up, and now I need to get, now I'm gonna take a pill to get down. So
Yeah.
it's really, that's why I'm surprised a lot of people have questions of sleep. It's a very serious issue. It's complex.
Yeah,
When
definitely.
does the patient know it's time to get a REM sleep study or a sleep study? At what point?
I think that would be more of a question to the family doctor where they've ruled out other coexistent or other issues. Like let's say mood part of it is ruled out. There's no anxiety or depression that's contributing to it. There's no other correctable things like there's no sleep apnea. There's no other physical comorbidities that could be affecting it. And it's like a diagnosis of exclusion. So then you say, okay, maybe we need a detailed sleep study where we're looking at your EEGs to see what kind of issues you're struggling with. And again, I am not a sleep specialist, so that would be a question better for the sleep specialist to say what prompts them to look at those disorders. But, if you've ruled out almost other things, tried a lot of agents, nothing's helping, then talking to your physician and say, hey, should I see a sleep specialist? That might be something that, if it's something chronic that you've struggled with, that may not be a bad option.
What do you think about
I think nortriptyline and amitriptyline both are pretty good anti-anxiety meds, but in terms of having the sedative effects, I think amitriptyline tends to work a little bit stronger compared to nortriptyline. So maybe a slightly bit better option. Mm-hmm.
It's really like, it's hard. I mean, and I don't do that often, but when I go out and I do sleep, it really is hard to wake me up.
Yeah.
Knock on your door, I'm trying to get you out, or
Yeah.
what?
Yeah, yeah. And again, I might not be the right person to ask this question, but like I said, there are different stages of sleep. Like there's REM sleep where you're nothing but your eye movement is happening, so you can't really move. There are conditions like REM sleep disorders, where or like there are conditions with like narcolepsy or things like that where your body is in almost a state where you're unable to do much or you're catatonic or things like that. So, maybe a sleep study will open more doors for you to recognize what it is. But again, I might be overstepping my boundaries here. Yeah. Once I do my sleep fellowship in the future, maybe I can answer your questions better, but we'll see. Yeah, sure.
Why do they make you go to pain management for medications that they're gonna give you a struggle to get? No matter what pain management, I've been trying to deal with pain management since I was little. I had lupus since I was 4.
Yeah.
And my mom would take me,
Mm-hmm.
and still giving me such a hard time that she would just stop it. So I take melatonin 4 times a day.
Mm-hmm.
I take Seroquel twice, and I still run and run and run to the point that I have like 16,000 steps a day.
Yeah.
That I'm moving that much. I'm in pain,
Mm-hmm.
but I don't rest.
Yeah.
And trazodone helped me because I thought about it, and she said she couldn't wake, they couldn't wake her up. Trazodone, you sleep deeply for like 4 hours, but then you wake up with energy. And I used to take it all the time with my rheumatologist.
Yeah.
I've had him for like 25 years.
Yeah.
And now they won't let him prescribe it, and why not? I don't understand that. I think that's just like horrible.
They didn't let him prescribe you trazodone.
They won't let him do it anymore.
Yeah.
You have to go through pain management. I don't see why if you have your own doctor,
Yeah.
you gotta do steps.
Yeah. Yeah, I hear you. I may not be able to answer all of your questions, but I'm just gonna address the portion about the pain management. So for treating a lot of acute and almost some chronic pains, we tried, we have a step ladder management. So we try to use easy, less toxic medications like say Tylenol or NSAIDs or other agents. A lot of our lupus patients, the pain is also coming from inflammation. So sometimes steroids are also used as like a breakthrough drug. Whenever you talk to a rheumatologist about pain, if there's high disease activity, we say that's stemming from inflammation. Let's control the inflammation. So if you've all noticed, we usually try to adjust your other immunosuppressive medications, if there's methotrexate, things like that, or switching to a different agent. Narcotics are something we normally don't deal with, like you said, because of the addictive potential. And when somebody is to a point where all these agents are not working and we are exploring what other options like narcotics or like other injections, joint related injections or other pain modalities, that's a completely different realm. It's just pain. They're dealing with pain day in and day out. So they have more experience for them to see what would be a better option. Is it narcotics? Is it an injection? Is it some kind of other IV formulations that they can use? So they're the specialists. So when we get to a point in our patient relationship where we've tried all forms of pain management and that's not working, or patients due to their comorbidities, like let's say kidney disease, some things cannot metabolize the agents that we give, then we usually don't have much options but to say, let's talk to pain management and say what they can offer you. Even if you do need to go on a narcotic according to their evaluation, it is safe to be with them because of the regulations, because usually they start with a pain contract where they tell you you have to do this many things. You submit urine specimens to make sure there is no abuse of the medication, and they know what they're prescribing, how much they're prescribing, because not only is dependency an issue with narcotics, it's side effects where your toxicity, let's say, right? People have respiratory depression, things like that. So something that needs to be very chronically like monitored. So that's not something we can offer much from the rheumatology clinic. So we always say, we are not referring you to pain management because we don't trust that you can take your opiates. I had a patient who was very upset with me once who said, I had surgery. I took pain medications for 5 days. I'm telling you now that I'm in pain. Why don't you give me Percocet? Are you saying I cannot handle my medication well? And I said, that's completely not the issue. They are the providers who deal with this day in and day out. They have systems established where they are regulating the use of these medications, from dose, side effects, to making sure there is no abuse of medications, both from provider and patient size, because we need separate licenses to prescribe these medications. So having somebody that's dedicated to deal with it it's easier. And not only narcotics, pain management does lots of things where they do non-narcotic related procedures to handle your pain. So it's like opening a new door for the patient. But oftentimes, yes, my patients do come back and saying they just didn't offer me anything, it was a wasted consult. So that I don't know how to help that portion, but from our aspect, we're trying to open more doors where we're trying to explore more modalities to treat pain. Unfortunately, that didn't happen in your case, so I'm sorry, but that's usually how it goes. Yeah, yeah. Sure, sure. Okay, all right, thank you so much.
I understand that frustration, and I know after that short term of pills that we get that some of us still are legitimately in pain. But on the flip side of that, I know way too many stories of people who did depend on it and they're not here today. They didn't mean to be abusers, but it took hold of them. They couldn't control it. But I will tell you, there are types of pain management companion therapies that do work. It happened to me. I was sleep deprived. I actually was very, very deep mentally because of it. And I worked with the clinic and I went through hypnosis. Now, for me, that worked. Okay. So we are in an incredible journey. And I would suggest you share those stories with each other of your success stories. Not everything works for, not everything's a fit for everyone. Okay. But I do want to say, we have a couple stars in the audience, and one of them is Devana in the corner. Devana, would you stand up? Yay. And the other one is Sonia over here in this corner, and they are featured stars in our magazine this quarter. They shared their incredible stories with us. We got another one who shared their story here. Where is she? Oh my God, I didn't see you. Okay, well, could you stand too? Such incredible, brave women. Some of them wanted to remain anonymous. It's like, I don't think that's going to happen. Okay. So I misplaced something on the back of your folders, not this, the folder. I'm looking for a silver star. Anybody got my silver star? There's one. Do you have it? Who has it? You do? Stand up. Anybody else have it? Come on, I know there's two more out there. It's a little on the back of the folder. Pick your folder up, look on the back. You're gonna look real hard because I have a present for you. Yeah, sure. We didn't find the other two? Well, congratulations on a little gift, okay? I don't know. So we're going to take a 5-minute break. I have lunch for you. If you like it, I made it. If you don't like it, then my sister made it. Okay. So we're going to take a little break. There's a box lunch for you. I hope it works to your flavor. And there's a restroom around the corner. We're going to come back. So we're going to eat your lunches at the table and have our speaker. Yeah, she wants you to take 5 minutes. Let's laugh at her. Okay. But let's do the best we can. Okay. Let's take a break. Oh, and our friends at home, time for you to go get a cup of coffee.